All right, welcome everybody. It is 1 p.m. on October 27th. Welcome. This is a special edition of the Florida EMS webinar. And the reason that we put this together is because the number of texts that many of you have received, that we have received, the number of phone calls, the number of people, kind of upset about this was so dramatic that we had to just say, hey, let's all get on a call together. This is not the Peter and Tanner show. There are many people on this call that I rely on, that I call upon, as we're trying to make these decisions and navigate these guidelines for our organizations. And so what we wanted to do today was to try to be as fair and balanced as possible. And the way that we're doing that is we have the smartest person in EMS on the call, and he's my co-host, Tanner Smida. So Tanner, many of you, if you don't know Tanner, you will sometime soon, because Tanner is a paramedic. He's also an MD PhD student in West Virginia, and he's also written quite a number of articles. He has many publications under his belt already. And for those of you who know him from the Florida EMS webinar, which we do every Friday, he's very thoughtful and he's wise beyond his years. So he will definitely balance me out. Dan, can you mute the people who are who have hot mics? Thanks.
On it.
Thank you. He will definitely balance us out here, and I've asked him to do that, and he'll have some slides as well. So just for some housekeeping here today, the goal of today is not to go through the entire guidelines, although I'm sure that over time we will do that. We wanted to hit some of the high points. We wanted to present the topic, present the data, and then open it up for conversation. And then hopefully all of you will leave here with at least some more insight in how some other people are thinking. We're not going to solve the problems today. I think one of the bigger overarching themes that I want to get across, that I've been trying to get across, is that EMS is a relatively new subspecialty, and it's becoming more and more clear as the amount of evidence, of out of hospital evidence, increases. The amount of people who care about what's in these guidelines also increases. So there may not be enough representation of EMS on these guidelines, number one, or how I feel that EMS as an organization, right, needs to move towards creating guidelines that are EMS specific, so that when the wording of some things come out in a guideline that's meant for everybody upsets only our group, it probably meant that the wording for that particular guidance wasn't good. And that's the mechanical CPR dilemma that you're going to hear about today. So please fill up the chat with some questions. We'd love to get you in. So if you have a question or thought, I'm going to have you unmute your microphone and just say it. If you have an opinion that's contradictory, put it out there, right? No one's perfect, and we want to hear what you have to say because other people need to learn from you. As always, we'll say to you, everything you hear today is not from any authority. I'm surely not, some guideline or some authority that you can go to your state medical director or to your medical director and say, we need to do this because of him. On the other hand, there are states in the US who are required to do things based on your state guideline and your state protocol, unlike the states of Texas and Florida, which are delegated practice states. So today is not for you to go and change your protocols based on what we're saying. We're trying to stimulate you to actually go and read these things, make sense of them, and figure out what you will do for your organization. After all, in the name is the word guidelines. These are not mandatory things that you must do. And with that being said, let me pass it over to my co-host, Tanner. Tanner, thank you always for joining and for being a big part of this and for preparing with me on this. I would love to hear what you have to say before we get started.
Yeah, so I'll say in preparation for doing this and discussing the guidelines, the first thing I did is I went on social media, so I took a look around some of the comment sections on Facebook and on LinkedIn, and I tried to pick the most contentious topics, the most contentious changes that were made to the guidelines that people seem to be upset about. So I'll mostly I tried to focus on those with respect to my slides, and I'll try to focus on those in the discussion today. Um, I also am going to try to take a pro guidelines perspective throughout a lot of this. So I saw almost universally negative reactions. So in this discussion, I'm going to try to be the more pro guideline person of the two of us, between myself and Dr. Antevi, although my agreement with the recommendations is not universal, as you'll see. So.
Okay, perfect. Excellent. I'm going to give people one more chance to open up your camera before I close it down. Because I know some people are just coming in here a little late. So if you want to open up your camera, now's the time to do it. If not, we're not going to see you. Okay, perfect. There you go.
Hey, Peter, I can't. Oh, it's on
Oh,
now.
is that
Yeah,
oh, is that Frank? Hey,
yeah.
Frankly
It's Frank Lee.
speaking.
Yeah.
Appreciate that. Right. All right, excellent. Before we start, what I want to do is give people a little bit of insight into some history. And why I want to do that is because um, it turns out that the guidelines are not always correct. And it is okay to push back. There's going to be something that Tanner and I bring up today that there are 100% incorrect today, October 27, 2025. I will stand here today and say that the AHA is completely incorrect. And if all of us keep voicing our opinions, ultimately, that's how change will happen. So let me take you into a little history. In 2015, when they came out with this, which said it is reasonable to give fluid in patients with septic shock. Okay, reasonable. Now, you probably say, why would they use the word reasonable instead of like, of course you're going to give a patient who's in septic shock fluids. Well, it turns out at the time that they got that recommendation came out of this study, which was the FEAST trial. And for those of you who know how I feel about the FEAST trial, what was the FEAST trial? It was in sub-Saharan Africa where they gave fluids to children with malaria or dengue. And it turns out that 60% of them had dengue or malaria. 30% had very low hemoglobins of less than 5. And then it turns out that when you gave fluids to the children with hemoglobins less than 5, 10.5% of them died, as compared to those who had a hemoglobin over 5. 20% of the patients in the no bolus group received blood for their anemia. And it turns out that in the group of the fluids, only 4% got blood. Lastly, if you were hypotensive, you were not even randomized into the trial. So this was not a sepsis study, but what happened was they took this study and they took it and they added it into the guidelines. Okay. In 2020, there were many more articles that got into the guidelines that all referenced this study. Okay. So what happens is what I've learned about these guidelines, which I'm concerned about, is that when something gets in, it's very difficult for it to get out. Now, why do I want to show you that is because in 2025, I wondered, is this guideline ever going to come out? And finally, um, they said here in 2025, this is the line that they added in about the feast trial. However, the guideline did not change. It still says it's reasonable to give kids with septic shock fluids instead of saying you should absolutely 100% give it. And then they just threw in a little line that says, oh, yeah, by the way, that study, the generalization of results from these studies is pretty problematic, right? So why am I telling you that is because you owe it to yourselves to not just look at the yellow, the colored boxes and say, oh, this is what they recommend. I want you guys to go in and look at the studies that they're referencing, and we'll talk about that later with the pediatric ventilation stuff and what ILCOR did versus PALS. But don't just take this information for granted because the people who are looking at it on a big population perspective, not from the seat you sit in, which is EMS. Okay, so We wanted to start off with the big one. Um, and it was basically vector change and double sequential defibrillation. Basically, they say here the usefulness of vector change for adults has not been established. Number two, the usefulness of double sequential defibrillation for adults in cardiac arrest with persisting VF or pulses VTAC after 3 consecutive shocks has not been established. Okay, well, let me show you how it has been established. And this is a guy who established it. For those of you who don't know, double sequential has been a thing since the first case reported in 1994. 1994. And then finally, Dr. Cheskis and his entire team from Toronto, Peel region, and beyond did a randomized controlled trial called the DOSE VF RCT. It was published in November 2022 in the New England Journal. I'm getting a little bit of feedback there. And here's what they showed. They effectively showed that you more than double neuro intact survival. That should be down here, 2.21, if you use double sequential defibrillation after the third shock. Obviously, there was some commentary made here that this was done during COVID. It had to be stopped early, et cetera, et cetera. But I don't think any of us who've been using double sequential would doubt the outcome of this trial. And there were subsequent trials or follow-up studies afterwards that continue to support it. So with that being said, Tanner, I'm going to pass it over to you, and then we'll open it up for the group. Talk to me about double sequential defibrillation and specifically about DSED and your thoughts as to why AHA said no to this recommendation.
Yeah, so I think that, well, I guess first I'll say, randomized controlled trials, randomized controlled trials are really how we know whether interventions work in clinical medicine, right? This is the highest level of evidence that we have other than systematic reviews and meta-analyses of multiple randomized controlled trials, right? There are many recommendations made by the guidelines that are not supported by that level of evidence, right? So we have observational evidence that suggests we should do one thing or another, and the guidelines recommend those things. So I do think that it is a misstep. I'll say that first, to not conditionally recommend this therapy pending additional evidence. Again, given the quality of evidence that we have here supporting the effectiveness of this intervention. That said, in emergency medicine, in critical care, there are plenty of examples of initial randomized controlled trials that suggested benefit from an intervention, so therapeutic hypothermia, vitamin cocktails, and sepsis, that later, whenever larger multi-center randomized controlled trials with maybe different inclusion criteria, maybe broader generalizability, when those later trials were done, these interventions were found to either not be helpful or to be harmful, right? So I can understand how they say, maybe we want to wait for another randomized controlled trial to confirm these benefits. However, if they're going to do that, I think they should be consistent across all of the guidelines. In terms of, so the reasoning that they provided, so they didn't say that in the guideline, to my knowledge. So they said that, there was a subgroup analysis of dose VF that showed that only patients with true refractory VF, so that's VF where you defibrillate and there's essentially no conversion of the rhythm. Those patients are the only ones that benefit, as opposed to the patients who have successful conversion of VF and then refibrillate prior to the next rhythm analysis. And they kind of say, so we can't really differentiate with current technology who's in refractory versus recurrent VF, and so we can't recommend this therapy. That doesn't seem to make a lot of sense to me, right? If we have a patient population and we can save 20% of those patients and we don't harm the other 80% with the intervention, why not just apply the intervention to the whole cohort, right? That would be my argument there. They also say that, there's some evidence from laboratory studies as well as a secondary analysis of dose VF that shows that maximal benefits are observed when the two shocks are delivered within 75 milliseconds of each other. And they just say, well, we think that's unlikely with manual activation of two defibrillators. Maybe that's true, but again, in the randomized controlled trial out there in the real world, this seemed to impact clinical outcomes, right? And so in the real world, it worked. And so, again, based on the results of that randomized controlled trial, I do still think personally that it should have been at least conditionally recommended.
Okay, so I'm going to push back a little bit on that first thing you said, which was that a study comes out initially, and then they do another study, and it doesn't work out. But at least you're saying that um, the initial study that we're looking at should be some high quality of good quality. You would agree
Sure.
with that, right? Okay.
Absolutely.
Right, because when you look at the other side of the table, and this will be later in our conversation today, but when we looked at the pediatric ventilations, when they took a 47 patient observational study from multiple pediatric ICUs, and they used that paper to then make a massive change to the guidelines, massive change. How do you reconcile that? Is my question, which is, yes, I get what you're saying, but at least be consistent with what you do and how you do it, right?
Right, right.
Okay.
Yeah, yeah, and I would disagree with changing practice based on a 47 patient observational study, right?
Okay.
I would think that that's a bad move. Right?
Yeah. Okay. So now, and I know that you have this data, and I know that there were people who were at the conference who texted me from there, but at the ERC, at the European Resuscitation Council, who also didn't go for DSED, but then you look at ILCOR that actually came out with a recommendation for DSED, right? So it comes down from ILCOR and then it goes out to ERC, AHA, etc. How could it be, Tanner, that the ILCOR says yes to DSED and then ERC, AHA say no? That's I guess I'll stop there and I'll ask you that.
Yeah, so I will preface this by saying that I am not, nor have I ever been part of any of these committees that form these guidelines. It's likely that they use slightly different derivation strategies for how they classify evidence. So like, AHA has their class of recommendation and their level of evidence. They have the structure by which they appraise the existing evidence. Those likely differ between these three organizations. And of course, right, there's different people that belong to all of these different guideline writing bodies. And so obviously there's going to be difference in opinion. There's going to be diversity of thought among all of the people who sit on these committees. And again, this is another problem I think that is universal across emergency medicine and critical care. There are very few interventions that we perform that have definitive evidence. So we have multiple randomized controlled trials that all point in the same direction. And so when you're in a space where there is not a lot of high quality evidence, this diversity of opinion, the diversity of thought, I think manifests a lot more strongly. And that's I think probably a reason why we're seeing divergent guidelines is that there's a lot of people who don't necessarily think we have enough information to really get to the right answer.
Okay. All right. Fair enough. So with the perfect segue for what I'm about to ask you, and I know you know the data, and I would like for you to actually say it, which is there was a late breaking abstract at the ERC, at the
Yep.
ERC. And can you tell us what that abstract said specifically about DSED?
Yeah, so the double D trial, it was it is an ongoing, I believe it's a Swedish trial of
It
double
is.
sequential defibrillation after the first failed shock, so earlier than dose VF. Um, and they presented pilot data at the European Resuscitation Council meeting. And although survival was not their primary endpoint, they just wanted to show feasibility. In the first 40 patients that were enrolled in this trial, patients in the standard arm, 9% of them have survived versus 40% in the double sequential arm, right? So this is an effect size that is pretty close to the effect size that was observed. It's larger than the effect size that was observed in the original dose VF trial, right? And so, again, this is additional randomized evidence that this is likely an efficacious treatment. I think that if the double D trial, the final results are published, I don't think there's going to be much of a debate after the next AHA, ERC, ILCOR guidelines are released. But as we talked about earlier, right, how many VF patients are going to lose their lives, before this next 5 year iteration? And again, right, this is pilot data. There's limitations, right?
Right.
It's not powered to detect differences in
It's not.
survival, but it's early data that suggests that this is an efficacious intervention.
Right. It's not, and actually, we in my agencies have moved DSCD to as soon as possible, and we just wrote up a case report that just got accepted in Jack with a
Mm.
guy who got it first. He got it as an initial shock. He walked out of the hospital, and it turns out that 3 days ago, Dr. Shepke happened to be riding, and they got another patient back with D. He was talking at the end after 5 DSCD shocks. So to your point, and I'm gonna open up the mics here in a second here, which is that when we look at our cardiac arrest data, which you should all know intimately at your agencies, when you look at the number of patients that survive, the largest bucket are the VF patients, the shockable rhythm bucket, right? Which is 20% of your total bucket on average will be VF. And when you look at the patients who don't convert after shock number one, the question is, what do you do next? And I'll guarantee you, and someone just put in the comments that how could you be more dead than dead? When you take those patients to a hospital that does not have ECMO, or is not going to take them to the cath lab with the Lucas running, which is very few people who do that anyway, they're going to call the code, right? So why not do it? What is the reason to not to do it? So I want to open it up here, and let's see. So I'm gonna call on some folks here who have been commenting. So Josh Kimbrell, from New York. By the way, we beat you last night. Sorry that Miami Heat beat the Knicks.
Yeah, amazing. The Miami actually won a game. It's impressive.
Yeah. So Josh, you are becoming a prolific researcher. You and your crony there, Judah. I see he's here as well. But go ahead and comment on what you just mentioned in the chat.
Yeah, I think it's part of my contrarian nature. I have to play a little devil's advocate here.
Please.
So I do think there should have been a stronger recommendation here. I would have gone at least class 2A with this recommendation. But I think there are some reasons to caution. So as you and I think Tanner both mentioned earlier, this is an underpowered trial because it was stopped early, which obviously to no fault of their own. But when this happens, we know that you can overestimate the treatment effects, right? When you don't get that full power, that's a serious danger, and we've seen that across trials that have been stopped early in the past. But I think one thing that has been brought up that I think is a really interesting point is when you do this like cluster randomized and you end up getting clusters to either, hey, we're doing standard, okay, now we're doing this DSED. And I think anybody that's implemented DSED can attest that this requires some like changes to your high performance CPR practices, some real focus on quality improvement. And so what you end up, there's a potential danger that distorts the effects of this Hawthorne effect, which is beneficial for the patients, right? That's a good thing. When you have this increased focus, you're really doing good quality improvement, you're doing really good training. But let's say the first two clusters, let's say it's like a stepwise cluster, for example, just to make it easy. So everybody starts without the intervention, and then we slowly bring on agencies. Every time we bring on agencies, we start training those people, and that training can improve performance because we also know, obviously, that high quality CPR, reducing chest compression pauses, and all of these other things can improve outcomes too. So I think that Hawthorne effect is a little weird. And I think when you look at the control arm, a survival of about 9%, I believe, in dose VF is actually pretty low for these witnessed shockable cardiac arrests. And so I think it'll be encouraging. I honestly think these trials will support the intervention as we continue to go forward. But I think there's some reason to like caution overinterpretation of the results.
Okay. All right. But again, these people are in cardiac arrest. They're more than likely going to be called when they get to the emergency department. These could be younger people, right? We've seen people in their 20s and 30s and so forth who, what in our terminology here, we call it a clean kill. We do everything on scene. Their end titles are in the 30s, 40s. They get to the hospital, and the hospital says, "How long you been working the code?" And we say, 30 minutes. And they say, "Okay, and they call time of death," right? I still don't see. I see what you're saying, but remember where this study was done. These are some high performing. I mean, the Toronto region, maybe some of the most high performing people I've ever met. And they do many randomized controlled trials. So this is not an agency that just started doing high quality CPR yesterday, right? This is a group of people who actually know what they're doing. But love your perspective. Let's bring in Judah. Dr. Crimebrook, let's hear your thoughts.
Yeah, so I think my kind of perspective on this is I come from the broader perspective of the evidence to decision framework, right? There's this question earlier that I really like that you brought up. Why do we have three guideline organizations that are all coming to different answers? And a lot of that comes down to the frameworks they're using. So ILCOR uses the GRADE framework. The GRADE framework has some really nice flexibility in it, in that you start where randomized controlled trials are valued more than observational studies, but you can actually get a randomized controlled trial that's downgraded because it's low quality, and you can get an observational study that's upgraded because it's high quality. And there's a lot of testing for risk of bias, whether it applies to that patient population, et cetera. So you take that framework, which GRADE has, within evidence-based medicine, has the longest track record of having reproducibility across judges, across raters, and whatnot. You go to ERC. I don't mean this is shade. Maybe I do. ERC is a lot of vibes, right? And so they're using a lot of expert opinion and kind of the GOBSAT method, good old boys sitting around the table, and they are making recommendations on the fly. You then look at AHA. AHA recently in these guidelines switched to taking ILCOR's advisement in and then making a decision. So I think we need to look broader at the framework by which we're actually judging evidence to identify why the recommendations are diverging. And then I think my other, key insight in regards to DSED in particular is that when folks are looking at the evidence, they're considering the randomized controlled trial. And, ILCOR did this with their GRADE approach, right? Dose VF was highly considered, but they also considered the fact that there are a lot of observational studies that actually contradict the effect measure that was identified in dose VF, right? And so there's probably a lot of confounding in those studies. Those studies are low quality and they weren't rated as high. But what I think happened with AHA, this is just my guess, is the logistical concerns, the lack of a structured grade approach to the evidence resulted in, I think if I'm not mistaken, there were actually some citations in the text. They were using some of these observational studies to justify that DSED might be harmful. I don't think that that's a wise approach, but they're just kind of my insights. I think it's broader here as far as like how we even rate evidence to begin with.
Going back, and I'm going to bring in Marv Wayne because Marv also mentioned this could be a logistical issue. However, I don't think you make recommendations, or you should make recommendations based on being concerned that someone may say, "Oh, you're recommending DSED, therefore I now have to." You're telling me I have to go purchase another device, and that device could be an AED, it could be another defibrillator. Is that what you're saying? And maybe Marv, I'll bring you in. Is that what you think that they're saying as to why they didn't do it?
That's really the question I think that they're saying, or statement they're saying. First of all, these are $30,000 devices.
More than that.
Well,
It used to be 30.
well,
If
special
someone
deal
for 30, let me know. I'll buy it.
yeah, we have the homeless striker. But on a serious note, they're expensive. There is a logistical issue. We covered 2,500 square miles. Can we get what to what to what effectively? We probably can. But there's also the pad issue, the issue of interface with Lucas. So the two things that we've at least looked at, our supervisors all carry the same device as the basic medic units, paramedic units do. So we at least have functional devices if supervisors are on scene, distance, time are a factor. Two, we've essentially gone to AP pad placement in the beginning, which we think is better anyway, but at least trying to move somebody who's on a Lucas from the standard pad placement, the anterior lateral, to an AP is kind of a logistical nightmare. So we start off in a potential position. I'm still soft. Sheldon and I have discussed this many times. I think the data is a res ipsa. You can't do really any harm. It speaks for itself. I think there's a potential. The only harm is logistics and cost. And so I would throw that back to the group. How many lives will we save? Actual, absolute number. Two, at what cost will we do that saving? And three, how many walk home from out of the hospital? So these are all the factors you need to step in. When we look at our CARES data, which is pretty impressive, it's 15, 16% go home with CPC scores of 2 or less. I'm actually putting together a talk for this overseas meeting on TTM. Looked at 2,000 patients, whittled it down, and we looked at who does well and why. And I think there's some important points to be looked at. But to say and to make, I just didn't, I don't like the way the AHA phrased it. And I would agree with the others that have had that same concern. So I'll shut up.
So I'm gonna go to the AP thing, right? For those of us who have been in EMS for, I mean, if you've been to any conference in the last 3 years, I mean, we've been talking about it at the Eagles, and maybe I'll bring Dr. Pepe in here if he'd like, but we've been talking about it for years, right? And then when Dose VF came out and talked about vector change, and then a lot of us have already switched down to AP, right? But now they have a recommendation that they're saying that the usefulness of vector change has not been established, right? When you
I
look at the
disagree.
impedance on these on the AP, which means that you're having more current going through, I think ultimately what it ends up doing, it ends up taking the people who are following, looking, evaluating, should I do this, should I not, etc. It just basically it just stops them in their tracks, and then they're going to have to start to ramp up again. All that momentum is completely lost, right? And as I pointed out with the fluids, which is why I pointed it out, and this is what I'm concerned about, is that once these folks get something in the guidelines, it's very, very, very difficult for them to remove it because it's saying, hey, we were wrong. And so is this going to change in the next 3, 4, 5 years? And in the meantime, what do you do if you're a state organization who has to wait until it gets into the guidelines until you do this? And that's who really we're fighting for. I mean, here in Florida, we can do what we want because if it looks good and we evaluate the data. But most people around the country cannot do that. And that's really my concern here. Let me yeah, go ahead, Mark.
Peter, one last comment. Electrophysiologists have been doing DSD for years.
Oh, yeah.
And when they induce VF and in some of the other induction procedures that they do, with great success. So just, it's not like, no, with total respect to Sheldon and everybody else, this didn't come out of thin air. This came out of real concept that already existed.
Right, since 1994, right. So, and then I'm going to bring in another concept here before I open it up to other people here, which is that when you go to the pediatric shockable rhythm protocol, and this floored me, okay? And I listened to the video painstakingly. Thank you, Lou, for sending me the videos. When they actually rolled out their concepts. So for pediatric shockable rhythms in the ERC, they use 3 stack shocks. And the woman said, she was an ICU doctor, she said, we have no evidence for doing this, but we're doing it. This is what we're doing. So there's no evidence for doing something, but you're putting 3 stack shocks. There is evidence for DSED, but you're not going to fight for that. And effectively, maybe I can use this thing here, but what is DSED? The word D, the double, I think is incorrect. It's not double anything, right? It's not, you aren't doubling the energy. I'm sorry to tell everybody, but the AL pads are going in one plane. The AP pads are going into another plane. We should call this 360 defibrillation. It's just getting more myocytes, and that's why it's better. That's why it's very clear that the Swedish study and the 3 other European trials that are going to come are going to show, more than likely, that early DSED is better than the 4th shock DSED, which is why that Swedish pilot study was looking the way that it's looking. So I'm going to stop there. I'll stop chattering. And I'm going to bring in some other people. Let's see. Anybody else want to comment? So Dr. Pepe, you run a very big conference every year called the Eagles, and you're always 10 years ahead of the game. I wonder, and you've written many hundreds of articles. What's your take, Dr. Pepe, on the DSED mishap here in the guidelines?
Well, just I think it was really great. Marv and I have been around since the Truman administration, I think, and so we've been at it. And what he has brought to your attention is about the electrophysiologist was absolutely correct. We knew this. Joe Arnado, for example, was teaching us you could do 84 leads and get someone shocked with 2, 3 joules, that kind of thing. It's how you get. So it's really not double sequential. The double sequential is actually, unfortunately, some language that I probably said early on, which was to try to do this simultaneously because you can't. You got to get it within a certain number of milliseconds. And so I would just take that out. What you really want to say is this is a multi-vector shocking, okay?
Yeah.
And that's really what you're doing. And what he showed was that, that the myocardium is not just doing this randomly. It's actually almost like twisting around, and you got to catch it at the right time. So the more vectors you have shocking at different angles, the better you are going to catch it to defibrillate it. So I mean, it's just something we've known for many, many a year. So I think it's pretty straightforward. The other thing is that there's things that work extremely well in the labs. This is probably a good intervention that we can't prove in the clinical situation, particularly because randomized clinical trials have become, particularly in cardiac arrest, have become so flawed. I mean, really flawed, because there's so many confounding variables. And as you know, I was like one of the first people who brought, I guess, both the randomized clinical trial.
Javier is an electrician, but
Use
he's
this,
All right. Yeah,
Jesse.
thank you for helping out. Yeah. Okay, we got it.
Thanks. Anyways, I'm sorry if I'm getting long-winded. I just wanted to say is that I could tell you 2 or 3 clinical trials that showed nothing worked when it worked so well in the laboratory. But the reason why is they were looking at the wrong, denominators and so on. I can, whatever it is. That's sort of what
Yeah.
you're probably seeing here. Okay.
Yeah. Yeah.
And I think this is the thing works, so you should be doing it. And we need to improve upon it though, and go to the next level is where we need to be going on all that. And just to get back to the clinical trials issue is that it for me is no longer the gold standard in cardiac arrest unless you're doing it very early on, like with people with ventricular fibrillation, still of course VF, etc. You might be able to show some differences there, and that's one of the reasons why this was so good in terms of Chesky's study, and then the ALP study, although the ALP study was using the wrong drug under those circumstances. So anyways, that's a whole nother topic, which I can come back and talk to you about. It's going to be very hard to prove something based on some of the clinical trials. There are clinical trials, by the way, that are out there. And when you get something that's positive effect, that's probably a true effect. Versus if you don't see any effect, it's probably because there's all these other confounding variables. Usually time is the biggest issue, quality of CPR, all the things we heard from the folks before. And then, of course, overzealous ventilation that knocks out the cardiac output, which may be a good segue into your pediatric thing, right?
Yeah. We're going to get there. Trust me.
Yeah.
All right. Well, thanks, Dr. Pepe. There's 2 items before we move on to mechanical CPR, which is, and I want Adam Parrott, our good friend from Lethbridge, in Canada. So Adam, talk about the fact that you do not need 2 monitors to perform DSED. You could use an AED. You want to talk about that real quick,
Yeah,
Adam?
sure. First off, everyone, you can hear me okay?
Yep.
Okay. So this is often a common misunderstanding, is that you need the 2 monitors in order to perform this skill, and the truth is you don't. What you need to have is a AED and 1 monitor. And so Sheldon put out a bunch of great training material with the PO region paramedics that shows you how to do this process, and he openly gives that link out to anybody who wants it. But essentially what it is you just simply need to use the AED first. And so you're performing your CPR, you're coming up to your 4th shock, and as we all know, or as we anticipate, that's probably going to be moved up to sooner than that. And so all it is analyzing and setting that shock with the AED first, followed by the manual controlled defib afterwards. And so when we look here in Canada, every one of our volunteer or career fire departments, at a bare minimum, has an AED on their trucks. And so there's at no point in time can we not perform a DSED. And then the other thing I'll add in here, Peter, is that I think we need to get away from saying double sequential. We've done double shocks in the past, and we know that those don't work. And so one of the problems that I noticed at the presentation from the AHA doc was they made reference to DSED being being a double shock. And they're like, oh, you just take it and you charge both monitors and shock at the same time, which is completely incorrect. And that's not the process in which it needs to go through. And so if we change that from double to dual sequential shock, then it starts to get away from what we've known in the past doesn't work. And it stops us using the same terms over and over again for different procedures, which just increases confusion, increases people looking at old studies that do not show the advantages of anything that comes out new.
And if I may, I want to echo what he just said. Is absolutely right. It's multi-vector, and in this case, we're just doing dual vectors here, and so that's an important point. And I agree. I mean, it's right out there. You got the AED. That's how we always did it years ago. Was that when we first got AEDs, we'd use those two, but you got to try to shock at the same time. By the way, so because then you'll miss it otherwise.
Yeah, and we're getting some great we're getting some great commentary in the chat. Is there anybody else? Oh, I do want to say one more thing, and then Judah, you can come back in and talk about what you want to talk about. But for a long, oh, and then Lou, I'll get you in next. But for a while here in the States, the reason people were not doing dual sequential what was because of this quote unquote risk of monitor damage. And I know that Dr. Chesky has been pretty vocal about that. He showed that in his study, if you do not press the buttons at the same exact times, the same exact time, you will not ruin the monitor, and you will not get any issues with the monitor. And I believe that the vendors are now becoming much more lenient with their and not forcing people to sign these documentation. So, but go ahead, Chief Lou Steinberg, go ahead.
So just a couple of thoughts. Not everyone has those two defibrillators, even an AED initially. Before that, I favor DSD. It's obviously proven its worth. So whatever I say is not against that. It's in addition. The studies I'm familiar with, though, no one addressed pad placement before in the before study. And I even asked Dr. Cheskis, was there training on that? One of the good things in these highlights, if you watched everything, was a big deal on precise pad placement. If you go in AL, that the one is vertical below the collarbone, the other one is horizontal up under the armpit. So if you're not starting with the right pad placement, you're actually just putting it in the right spot, doing a vector change. And we know vector change is part of this. So it's a big deal to me to make sure the first shock efficacy, if it's going to work the first time, the rest is a moot point. So pad placement is like a big deal. And again, they've addressed it in several places in the guidelines, all three agencies. So,
right, that's a great point. You got a heart from Diana there. And I would also say, though, that the AP pad placement should be where people start. I think that's pretty obvious.
Yeah.
But again, what paper is going to come out next to say AP first? That's the point. What's going to end up happening now is we're all worried about DSED, but people are forgetting about the fact that AP should be first. Are we going to need another study? So Tanner, let me ask you, are we in order for us to get AP pad placement as a thing to do, what's that going to require from a research perspective, from your opinion?
Well, I believe, and maybe some of our Canadian friends that are on here can help us out with this. I believe that Dr. Chesky's and some of the collaborators in Canada are doing kind of a before after. They're looking at implementation of AP first in some services to determine if maybe a trial of that specific question would be feasible in the future. If I'm not mistaken, almost all of the trials ongoing, they do not include a vector change only arm. So all of the ongoing trials either look at standard versus double sequential initially or after one shock, or or true duplications of dose VF with aftershock number 3. But again, this would be an easy trial to do. And as I've said before, right, I think in emergency medicine and EMS, I think we need more trials. I think if we don't really know the answer to a question, we need to randomize people, right? That's the way to figure it out. And so if anyone out there has the capability to do that trial, I would strongly encourage them to pursue it, right? Because that's the only way we're going to get the real true answer.
Well, our friend from New York says it would be really easy to stepwise cluster randomized trial AL versus AP. So Josh Kimbrell. Let's get her done. Okay. I'm
Peter,
gonna,
one comment with that
yeah.
AP. If you watch the videos on the pediatric, the ERC has one method of AP placement. The AHA had two different methods, and they were asked, well, why do you have an alternative? And the woman said, that's a good question.
Oh, there were a lot of those. There was another one where they said the blood pressure should be for post-ROSC should be moved to the 10th percentile systolic. So they said to the AHA person, "Did you add that information into the guideline?" She says, "Oh no, we didn't." But the ERC did actually. So all right, let's move on. I know we're going on, but this is another big one here. So first, I'm going to talk about the information I got out of ILCOR, and I'm going to want Tanner to talk about this as well, which is they have shown for a long time that there was no difference, meaning that you're not going to expect to see an improvement, but maybe they're exactly the same. And then, were there studies that actually showed that people got worse? Tanner will talk to us about that in a second. But what I wanted to bring up before I pass it over to Tanner is the recommendation actually from the AHA right here. And I want everyone to kind of wait, sorry, where did it go? Right here. Sorry. Notice what they did here. They said in adult cardiac arrest, the use of mechanical CPR devices may be considered in specific settings where the delivery of high quality manual compressions may be challenging. That's us in EMS, or dangerous for the healthcare professional, as long as rescuers strictly limit interruptions in CPR during deployment and removal of the device. So this is an important one because it does say use it if you know what the heck you're doing with it. Then at the very bottom, they go ahead and they add in a level, it's a 3 with no benefit. The routine use of mechanical CPR devices is not recommended in adult cardiac arrest. So with that setup, Tanner, talk to us.
Yeah, so I'll take the pro guideline position here. So my thought is that this is a reasonable recommendation that's made by these guidelines, and it really hasn't changed very much since the last iteration, right? So we now have multiple randomized controlled trials, right? Again, that kind of highest level of evidence that randomize people to early application of mechanical CPR or manual CPR. These have been with different devices. So they've used the band type devices. They've compared the piston or plunger type devices versus manual CPR. Overall, looking at all of these data together, there is no difference in clinical outcomes. And several of these trials actually showed worse outcomes with mechanical CPR devices. So the Paramedic 1 trial, the predecessor to the Paramedic 2 trial, the Epinephrine trial that we're going to talk about a little later, that looked at the Lucas versus manual CPR, they found that patients who got mechanical CPR routinely during cardiac arrest resuscitation actually had worse neurologic outcomes. One of these trials was actually stopped early. Outcomes were so bad with early routine application of mechanical CPR that they said, we have to stop this study because we're hurting people, right? And so in the context of this evidence, I think it is very reasonable. And I think the AHA and all of these guidelines are sort of, they have to say that they can't recommend the routine use of these devices, right? And early routine application of these devices has almost certainly no potential to benefit people and does have the potential to hurt people, right? Now, that said, right, I also think it's very reasonable if you are going to be transporting a cardiac arrest patient to the hospital with ongoing CPR, right, which should be a relative rarity, right? If you are going to be doing that, I think every one of those patients needs to have a mechanical CPR device on them for provider safety, for clinician safety, if nothing else, right? I saw a lot of criticisms of this online, and I saw accusations that the AHA and these guideline bodies were corrupt, that they're written by interventional cardiologists who have never done CPR on the back of the ambulance, and I'd like to see them do CPR for 45 minutes in a snowstorm going across the city, you know. And then other people saying, I've had cases where this definitively saved lives, right? I had a 4-hour hypothermic arrest Without mechanical CPR, we never would have been able to save them. Or I had a PE and they had to get 45 minutes of CPR after thrombolytics were administered in the ER and they walked out of the hospital neurologically intact. They never would have been saved without mechanical CPR. And I would urge you to think of this from the perspective of the guideline writers, right? They're writing guidelines for the population average, the average cardiac arrest patient in the average situation. And so, yes, it is possible that the 1 in 1,000 cardiac arrest patients that needs hours of CPR because of hypothermia or an overdose, a toxicologic, because all those things, maybe those patients need mechanical CPR to be saved. But if you're sacrificing in that same 1,000 patients, if you're sacrificing the lives of 20 or 30 cardiac arrest patients who would have survived if you just defaulted to manual CPR, again, the hands of the guidelines are tied. Their job is to improve population level outcomes from cardiac arrest. I talked to Dr. Antevi earlier, and he has agencies that, all comers, they're seeing over 20% survival from cardiac arrest, far above the national averages when you look at CARES data. And his agencies are using mechanical CPR, right? And maybe applying early and routinely, right? But the guidelines aren't written for the incredibly high performing agencies like the ones that Dr. Antevi is the medical director of, right? These guidelines are written for the average agency and the average patient, right? And so based on the available evidence, I think that they made the right decision here, and I think that these recommendations are very reasonable.
Let me ask you then, Tanner, and again, I'm not a lawyer. However, why not just leave the top one and not add the bottom one? Why did they have to emphasize? Because I think this is where people got confused, and similar to the pediatric fluid issue. Why do you think they did this? It was very clear in the very top. Why did they have to go to routine use at the bottom and confuse people?
Yeah, so I think that this top recommendation, right, that specifically says that we can use them during transport, we can use them in these challenging situations. That one was put in there to protect us, right? That was put in there to benefit patients in the pre-hospital setting, right? The real question that the guidelines have to address is we have all these randomized controlled trials. It's the guidelines' job to synthesize the evidence from those trials and make an official recommendation. So this class 3 recommendation, that is the one that has to be in the guidelines, right? We spent a lot of money and a lot of time and we experimented on a lot of people to get that bottom row, that 4th recommendation. And so I think that my opinion would be that this top one is essentially put in there for us to protect us and allow us to continue to use these devices to enhance our own safety and for those kind of edge cases, the hypothermia, the cases where this might really matter.
Okay, so I'll ask you another question then. If you were a betting man and I brought you 5 humans and I told you that I was going to put those 5 humans up against a robot, who do you think would win?
I think the robot would win.
Okay. All right. So what is it about this mechanical CPR robot that is not recommended, that enough so that and all of us have seen it, and I could tell you, I guess I'll start by saying that when I travel the country and I ask people, do you have code stat or case review? That's the Stryker product and the Zoll product for knowing exactly how many compressions at what rate, what compression depth, all the metrics. And I get very few people who actually know that information, who even gather that information. So you're telling me then that I go to the standard system out there, the standard hospital out there, where they bring me a 4-foot nurse who's on 2 stools doing CPR, that those people are better than the robot. And I think that something about that just doesn't add up. And that's really what I think people are trying to figure out. So what are your thoughts on that? And I'd love other people to come into this too.
And so I totally agree with you. I think that there are other mechanisms of harm that may be at play, right? So it may not just be about the CPR, right? So of course, the one that we always talk about, right, is pauses in CPR and delayed defibrillation that result from fumbling around and putting these devices on early, right? We can address those with training. We can make sure that we are, maybe we get a couple shocks on board before we deploy these devices to make sure we're maximizing the benefit that's derived from those first couple defibrillations. We can make sure that we're doing kind of, stepwise placement of these devices, right? So we have minimal interruptions in CPR and still high CCF prior to defibrillation. But I think there's other ways that these devices could cause harm too, right? Again, out there in the real world, I have seen cases where, the devices are not properly positioned, right? And so they're not actually providing effective blood flow because they're compressing the abdomen, they're compressing the spleen, the liver, at NEMSP, there's plenty of abstracts that have documented compressor walk, how the compressor kind of moves around on the chest. That isn't as much of a factor with human CPR, right? With every compression, we can adjust the vector of the force that we're providing, and we can stay in the same spot on the patient's chest. So maybe that's one way that it causes harm. Maybe it's ventilation quality during manual versus mechanical CPR, right? There's plenty of mechanisms. I agree. In a perfect laboratory setting, the machine's going to outperform the human. But out there in the real world, there's other variables. There's other factors that might negatively influence survival that we're not measuring, that we're not even aware of. And so that would be my argument is the trials, the real world evaluation, some of them showed real evidence of harm. We don't know where that harm's coming from, but it exists, right? So that would be my argument there.
Yeah, no, there are a lot of great comments coming in about the walk down. We actually now use a Sharpie and we actually circle it so that we can actually see if it's walking or not. Scott Youngquist did a great study showing that depending on, even with manual CPR, that you may be right over the aortic outflow tract and you may be doing nothing for the patient that's any benefit. Yeah, go ahead.
Another thing is, in some of these trials specifically modified their treatment algorithms to specifically minimize pauses, right? So like for example, in at least one of the trials that looked at the piston type, the Lucas device, they actually delivered defibrillation while the device was still running, specifically to minimize chest compression pauses and increase the chest compression fraction, right? And there's some data out there that if this is something that's being done, whether the defibrillation is delivered while the chest is compressed versus decompressed might actually impact defibrillation success, right? So again, I think there's a lot of factors here that might not necessarily be captured by the classical arguments about whether one's better than the other.
Yeah, perfect. And I don't think he knows I'm going to call on him, but I want Marshall Frank from Sarasota County, big agency, great medical director. He and I were texting over the weekend. But this topic, and someone just mentioned it here, that we should be doing manual first. We shouldn't be rushing off scene. We should be treating these patients unless there's a reason to actually have them leave the scene. So Marshall, are you available to make your comments?
Yeah, of course. Thanks, Peter, for asking me to. So in our system since 2020, since that paper came out in JAMA in 2020, showing a quite linear representation of patients who have on-scene cardiac arrest resuscitation versus intra-arrest transport, we saw that there's a linear relationship that as you have intra-arrest transport, your rate of discharge home with a good CPC score goes down.
Is it possible to get them pressed?
And so just based on that, we don't transport intra-arrest at all. And our return of circulation scores and our discharge with good CPC scores outstanding is better than the state. We're in Florida, and it's better than the nation. And we resuscitate these people on scene until either we terminate based on our protocol or we have return of circulation and we transport. And I was able to work out somehow 5 years ago. I don't remember how I did it, so I can't guide anybody really. But I was able to work out with with every hospital in our catchment area that they'll take our deceased patients that we tried to resuscitate if they're in the back of our ambulance, in the back of our rescue. If they're on the scene of the house or what have you, we leave them with law enforcement or whomever. But if they're in the back of our rescue, we transport the deceased patient that we tried to resuscitate, that we terminated, and the hospitals take these bodies and properly perform a disposition of them. And
rather than it being a crime scene in the back of the ambulance, basically.
Right, because then and we're waiting for the ME or for a nursing, a funeral home or somebody to come get them in the back of our truck. And, to be honest, I think that's well over an hour. And we're certainly not going to take them out of the truck and bring them in somewhere else. So, I mean, that's not feasible. So the hospitals have agreed to take the bodies and perform appropriate disposition. And after we did that, our ROSC rates went up, our CPC scores discharge went up, and and I think just going back to Dr. Chesky's paper with DSD, you're talking about one paper, and there's concern that there's a lack of power to it. But this is one paper also, from 2020 in JAMA that I think is a groundbreaking paper. And I think we all know that, transport, like Tanner said, transport into arrest is dangerous for the community. We're taking these patients with red lights and sirens, 70 miles an hour with an ambulance that weighs, I don't know how much they weigh, but a lot. And, to do what? To have the emergency department or the emergency physician call the patient within 30 seconds. So that's why we're doing what we're doing, and it's really showing that it's working.
So just to reiterate, what would you say percentage wise is your use of mechanical CPR at Sarasota?
No, we don't use it at all.
So you're not using it. You have zero.
Nope,
No use
zero.
of mechanical. Okay.
Yeah.
So in other words, if you have a patient needed to go to the cath lab or needed to go to ECMO with a refractory, what do you do? It's just manual the whole way?
Yeah. So if we don't have access to ECMO in the emergency department in my system, so if that was the case, if somebody were to come down to the emergency department and cannulate, like they're doing at Memorial Hospital on the other side of the state, yes, I would 100% advocate for that.
Okay.
But we don't have that now, so but if that was the case, I would advocate for it. That being
Marshall,
said,
can I interrupt for a second? Marshall,
Sure.
you guys are paying attention to the end tidal CO2 and the quality of the CPR that you're doing, correct?
yeah, totally, and that's part of our our termination guidelines or protocol. With an end, we look at the end tidal based on we determine termination based on the end tidal, among other things. Witness arrest, shockable rhythm, bystander CPR, duration, and so forth.
Okay, excellent. Are there any other agencies? I know Tom Bouthillet, who formerly was the EMS chief at Hilton Head, also feels the same exact way that you do. Is there anybody out there here today who also has seen a spike in their numbers, increase in their numbers, CPC 1, 2, without the use of mechanical CPR? And if you do, you can unmute yourself. I mean, it would be nice to have a poll here, but I would say just to kind of summarize some of these things for the agencies who we are using mechanical CPR, we do advocate for manual, high quality manual CPR early on, and then we try to stay on scene. And just for people to know, the average termination rate in CARES 2024 is about 40%, 40%. And if you're an agency that is terminating, you should be terminating somewhere in the range of 40%, which means that there's 60% that you're either not terminating or you're moving, right? And it'd be nice for everyone to kind of look at their systems, know exactly what you do. You should know exactly at what time you transition to either the Lucas or the Autopulse, because it should be very clear in your code stat or case review data.
And I will also say, so I just did a study looking at mechanical CPR devices in the ESO data set. And so nationwide, most people that are using mechanical CPR devices are not using these things for transport. They're putting them on within about 4 minutes of scene arrival. And so the practice pattern currently in the United States is essentially the same practice pattern that we saw in the randomized controlled trials that showed harm, right? These are not being used to facilitate transport or late in codes during prolonged resuscitations. Like they're being used as to free hands early during the resuscitation.
And so what is it about the early placement? Do you think that if we were a fly on the wall with a video camera, those people would just not would not have hands on chest while there's the device. Okay, let's all bring it in, and nothing's happening to the patient? Is that what you think is happening?
I think that there are probably interruptions, delays to recognition of shockable rhythms. I think we've probably all been on codes where, the device, you go to click it into place and the guy's shirt's, in between the device, and then everybody's hands off fooling around trying to get it clicked in. I would bet that is at least part of the mechanism of harm is people get distracted and kind of get tunnel vision as we've already we've rolled them, we need to get this thing on, and defibrillation gets delayed by 40 seconds or however long it is.
And if I had $1 for every time, Tanner, I heard from people that as soon as we implemented mechanical CPR, our rates dropped. I mean, you've heard that, I'm sure, as well. And so what we have to do, we have to go back and retrain everybody. So we've created videos, and people can look at it online. I can share it here too if I can find it. But we have very clear videos on how to actually place and then also remove these devices. Go ahead, Dr. Wayne.
Yeah, hey, Peter. So let me approach this with a kind of a hybrid approach.
Okay.
I cover a pretty large area, 2,500 square miles. It's rural as well as central. Our biggest city is 150,000, so it's all and about. Our BLS providers are iGel trained, AED equipped, and we require continuous quality management of CPR. Okay, good concepts, great. But the problem is two problems. One, number of responders in the rural areas, how many we can get to a call, responder fatigue, and then concept of transport. So when we went to mechanical CPR, for which there was some skepticism and a lot of discussion, and we've been doing it for quite a while, the decisions was made based on you can't give up great standard CPR to substitute mechanical CPR. You got to have both. We try to look at Mike Levy's data on switchover. We have a two-phase process. Our goal is under 10 seconds. I think we meet maybe 50-50, but we're definitely under 15 seconds when we've timed it. We definitely prepare for transport if we think that's a feasibility, because we all know the difficulties of going up and down stairs and all the logistics to move to the medic unit. So looking at that concept, we try to address the use of mechanical as an adjunct, not a substitute, for exceptionally good high-performance CPR. And I think if you take that attitude, you're going to be better with the whole process. Now, let me put a little caveat in the whole thing. My medical examiner, when we started Lucas CPR, was on my doorstep about twice a week, telling me how we crushed the human body apart with Lucas. Showed me pictures. I've got them all. And wanted to go to the medical society to have Lucas banned. You could say the same thing, I'm sure, with the autopulse. The issue was, what was standard CPR doing? And he was not taking a particularly good look at those patients who were getting standard CPR. So we had a true comparison. While we had a preponderance of mechanical, when he started looking at the standard CPR, well, the injuries might be slightly different. They were very equivalent. So just know you are going to do damage with CPR, and you might do an equivalency or a different process damage with mechanical CPR. But you need to walk into this whole program knowing, one, you need to create a hybrid of how you use it, and two, you need to understand what it does and doesn't do.
Interesting. Okay, that's very good data. I like that. Let's go to Adam.
Yeah, I was just going to kind of reiterate what Marvin just ended up saying. When we look at our system specifically, our SOG is written that the first 10 minutes should be done as manual CPR before we transition over. We know that that's not happening. We do get into our mechanical CPR much faster nowadays because we have more devices available to our staff. But if we think that we can show people how to use these devices once and never touch them again until they actually need to use them, then we will never show a positive outcome. And so we give feedback on every one of our deployments. We have systematic approaches where we only allow a 5-second pause per pause in order to align the auto pulse and get everything kind of hooked up and set up. And that if we're not giving that feedback back to the practitioners, they're never going to improve, so they'll never know. So these studies that we're going to do, we can randomized controlled trial as much as we want, but if we think that we just do this once and and then everybody knows how to do it, we don't have to worry about it, then we'll continue to have this conversation for another 10 to 15 years.
Right. And you know what? I'm going to double click on that, just giving everyone some data. If you're in a population of 100,000 people, you're probably going to run 50 arrests. Of the 50 arrests, 20% of those are going to be shockable. And with the potential of you having to kind of move them if you have ECMO type of thing. All the rest are going to be asystole PEA, and the percentage of patients who survive from that is a fraction of 1%. So if you have 50 patients, 20% is 10. What percentage of those are going to be in refractory? Probably one or maybe only one or two patients in total. And so if you're in a 100,000 population like I am here, and I have 180 medics, and you're only going to have very few patients who are going to require this, and you haven't trained on it very well, you can only imagine why, and people are making comments in the chat, why the placement of the mechanical device, which may seem like, oh, it's going to be helpful, is maybe in reality more harmful. So fascinating conversation. And probably we're not going to solve the problem here, but I think just to kind of put a bow on it, let's go to Lou, and then I'll have kind of Tanner give us the wrap up of mechanical and where he thinks this whole thing settles once all the dust settles. But go ahead, Lou.
Just one quick note, it depends who you have there and what the mentality is. Excuse me. So, in our region, we have 7 people in a cardiac arrest. No problem to line up compressors. If you look at Seattle, they send 2 engine companies, plenty of compressors. What happens if you only have 2 or 3 people on the crew initially? You're not going to get much else done. The problem I found, and I had an EMS captain challenge me, I said, right away, you got to put your hands on the chest. Doesn't require anything else. That person's been down X amount of time, get some perfusion going. His logic was, well, I have to pause anyway to put the device on. I might as well do it in the beginning. I'm like, no. They've been without blood flow to the brain. You have to start that. So it's a matter of getting that mentality across that, hey, get on the chest, stay on the chest. At some point, you might have to switch over. But like you mentioned with the video, it's got to be practiced so it's a swift, smooth turnover.
Yeah. And if anyone calls me and says, hey, would you mind looking at my agency? I'm going to ask them for all of their coach stats or their case reviews, because you could tell a whole lot of what's happening at those agencies that they have no idea is even happening. I mean, you see some people, the monitor turns on at, let's say, 12 o'clock, and then there's a whole lot of nothing happening for quite a while. You see very fast compressions. You see a lot of pauses in compression. So it's very difficult to just blame it on and someone mentioned it, Ari mentioned it. Exactly what is the problem with the mechanical device? It's probably not the device that's the problem. Charlie Ingram, Dr. Ingram, go ahead.
Yeah, so in my sleep deprived state today after working overnight, I think that the mechanical device to me becomes an extrication device and a movement device. It's not a compression device anymore, right? Yes, it has its utilization. I would rather see it attached to the scoop. When we move onto the scoop is when we move onto the device. And if you're not on a scoop, then you don't need to be on the device. If you're not on a stretcher, then you don't need to be on the device. And I totally agree. It all has caveats. Even in the great city of New Haven, there was still an area of New Haven where first due for a cardiac arrest was a single medic in a fly car, and he had a Lucas. So yeah, if you were completely by yourself, like it might be one round of CPR and then figure out how to get a Lucas on so you can get a monitor on somebody and shock them, right? Like there are those scenarios in play, and I think the guideline still allows that, right? Like I think that first spot in the guideline, that level 2 recommendation is still there. But at the same time, I can see this as a general guideline saying that we shouldn't be putting it on when we have 9 people on an arrest. Like, yeah, that's why the engine crew is there. They should be doing CPR, and it's not a compression device, it's a movement device now for safety. So I've never seen good compressions going down the stairs, right? That is the utilization of mechanical CPR, I promise.
Okay, so Tanner, I'm going to come to you here in a second, but now I'm going to pose the question here again, which is, are they blaming the wrong thing here? And that's really the ultimate question here, is that they're saying that the routine use of mechanical CPR devices is not recommended, when in fact, and you mentioned one of my agencies, Palm Beach Gardens Fire Rescue, we are year to date, we're 22.7% neuro intact survival. We use these devices when needed, not all the time. So you can't tell me that I shouldn't be using them when I have a very good track record. So it's probably not the device at all. So let's kind of put a bow tie on this and go to Tanner and say, Tanner, if you had to kind of give the audience here your overall summary of the mechanical devices, go for it and tell us what you think.
Sure. Yeah. I guess I'll say first, the American Heart Association is not coming for our Lucas devices. We are still permitted to have them on our ambulances, and I'm sure we will for years to come, and their use will continue to increase, whether that's a good or a bad thing, right? But from the perspective of a guideline writer who has public health as their primary interest, and they want to improve the average survival rate for the average cardiac arrest patient, the average population at the average agency, the preponderance of the evidence suggests that the use of these devices is not going to improve survival or neurologically intact survival, right? So if you don't have one, don't feel the need to run out and buy one. But of course, right, there's always going to be at a clinician level, you have to make judgments about if you have a patient who could benefit from these devices, whether it's they need transported for ECMO, right? Whether they need to be receive prolonged CPR because of some reversible etiology that only the hospital can fix, right? That would be my summary.
Right. Good. And I think that just the message to everybody that focus on the BLS part of CPR and focus on your times, focus on your compression rate, your compression fraction, your ventilation rate, your pauses, and don't think that some device is going to magically make all the other BLS aspects of care improve. In fact, it'll make it worse. And I think that's really the big take-home point here. Okay, so as they say, what did Reagan say? It's the economy, stupid. I would say it's the BLS, stupid. It has nothing to do with the device. Okay, good. We have lots of more topics to talk about. I do want to move into the next topic, only because people know how I feel about this, but I do want to highlight some things. And we're going to go to ventilation for kids. And there's something that that you almost may miss if you don't see it. So I'm going to point it out to you. Let's take a look at this class of recommendation. This is a 2AC limited data LD. And you can see here that for ventilation, this is interesting. They separate number 1 and 2 out between out of hospital and in hospital. In infants and children with out of hospital cardiac arrest, it is reasonable to perform BVM rather than advanced airway, tracheal intubation or SGA. However, infants and children with in-hospital cardiac arrest who do not have an advanced airway, it may be reasonable to perform BVM or advanced airway interventions, tracheal intubation, or SGA placement. So notice there's a couple of words different here, but Tanner, you haven't seen this. I didn't prime you with that. And maybe you have a legal brain as well, a medical brain. But why do you think they differentiated here between the out-of-hospital clinician and the in-hospital clinician?
Yeah, so and it's interesting. They don't cite in their level of evidence that there's randomized evidence to support this, but there has been an out-of-hospital randomized trial of intubation versus bag valve mask ventilation in pediatric patients. And so, I would, if I had to guess, I'd say they're probably leaning a little bit more heavily on those data, even though in that trial, although most of the patients enrolled were in cardiac arrest, not all that were enrolled were in cardiac arrest. So this recommendation would be based on a subgroup analysis of that randomized controlled trial. So maybe that's where the difference in wording comes from.
Or do you think that for some reason the people sitting in this room just say that that's EMS and they have less experience than, I mean, I can walk into many pediatric emergency departments and show you people who have less airway skill than some of my paramedics.
Yeah.
Now, again, not everything's created equally in different departments, but and again, I don't know how to answer this or how they came up with it, and you have some good thoughts there. But I just thought it very interesting that they separated out and they say, you EMS people, you ought to do BVM. And I don't know any EMS person who doesn't carry a supraglottic airway. I haven't met them yet. If they're on the call, please raise your hand. Let me know who you are. But are you going to now not start placing your SGAs because of this recommendation. I just found it fascinating. And that's not the worst part of this. The worst part is this, which is stayed in here from 2020. And let me give you the reasoning that they put in here in the guidelines. And I hope that people who wrote this thing are listening. I've tried calling you, writing you, texting you. You don't answer me. So here we go. One small multi-center observational study of intubated pediatric patients, and they didn't write in here that this is in an intensive care unit, found that ventilations at least 30 per minute in children younger than 1 and 25 in older children were associated with improved rates of ROSC and survival to discharge. We're going to get to those patients in just a short second. There aren't that many of them. A ventilation rate of 20 to 30 was selected to account for higher physiologic respiratory rates in children, the preponderance of respiratory etiologies in pediatric cardiac arrest, and association with improved survival and avoidance of higher ventilation rates that were associated with lower systolic blood pressure during CPR. All from that same paper, okay? By the way, let's review that paper. And by the way, this was the folks, and if you go look at here, the folks who wrote that paper are also the folks who write the guidelines, okay? And so here it is. This is the interesting part. And again, paper number 5 was that same paper I'm about to show you. This is where it came in 2020. And here's the paper, okay? There's the same authors. And you can see here that if you can't see it in the back there, 97% of these patients were in the ICU. There were only 47 patients overall. All of them were intubated before their cardiac arrest. Majority of them were on a pressor before going into cardiac arrest. And they all had monitoring, A lines and all of that, okay? So not the patient that you see in your work here in EMS. Here's the part that really bothers me, which is they're calling a cardiac arrest rhythm in kids, children who actually have a pulse. So PALS is called bradycardia, cardiac arrest, for a long time. We don't do that for adults, but for some reason, now that they include bradycardia as a cardiac arrest rhythm, magically, all of those patients can get included in this study. So you have patients who have a heart rate, who are getting ventilated. And remember, if you have a heart rate, you're producing more end-tidal CO2, and therefore, your ventilation rate may have to increase, as opposed to what we see, asystole PEA, which in this case, none of them survived. None of them survived. Okay, so 74%, in my opinion, were not even dead, and they end up in a cardiac arrest paper. Moving on, showing you here that when it came to ILCOR 2020 stayed at 10. So ILCOR said no, AHA said 20 to 30, and they said it was a single center, it was really multi-center observational paper, and they said we need more evidence. Great. So I was all on ILCOR's board. Let's take a look at what ILCOR came up with this time. And this is ILCOR, not AHA. There's currently no supporting evidence to make a treatment recommendation on a specific ventilatory rate. And by the way, it says 2024 because ILCOR came out with this, this early guideline. They formalized it in 2025. But basically, there's no supporting evidence to make a change. Great. But then they added this in this year. For cardiac arrest that occurs with an advanced airway, the use of ventilatory rates greater than 10 may be reasonable. The PLS task force suggests using ventilatory rates close to age-appropriate rates with avoidance of hypoventilation and hyperventilation. They have zero additional data to say that. So I wonder to myself, and again, I'm not going to ask Tanner this because he's not going to know either, but how could it be that the last time you said we need more evidence, no such evidence came about, and then they snuck this thing in? Interesting, isn't it? So they said, and then wait, I'm going to go now to the okay, so that I'll stop there. Okay, so going back now, and Tanner, I'm going to bring you in for this one too. Oh, I see Paul wants to come in. Paul, I'll go to you first. How could it be that these recommendations are out there, 47 patient observational trial, and then the ILCOR folks kind of snuck this in? What do you think is happening here, Paul? You're on mute. You're on mute. You're on mute.
Could I quickly go back to the first thing you were talking about the issue about the BBM versus, and then I'll come to this
Sure.
real quickly. I don't
Yes,
want
yes,
to
yes.
dominate
Yeah,
things.
I would love to hear about that. Yeah, yeah, talk
Okay,
to me. Go
good.
ahead.
Okay, so this was done with a study that they were having problems with paramedics misplacing things in LA County back about, I don't know, 30 years ago, whatever it was. And so we had done some, studies in children, et cetera, both in Seattle and Houston, and we had, there were some positive. We were using endotracheal tubes, and we actually correlated with a good outcome in kids, but maybe it's because how we were using the endotracheal tube. So, but these guys weren't getting that, so they actually trained 20. And the reason why I know this is you can talk to David Purse, would be the expert to come in here, but he was the head of paramedic training around that time. They trained 2,600 paramedics to do about 125 pediatric intubations the next year, which means you get a chance to do a tube once every 20 years. And if your partner gets one, you get to do one every 40 years. So that's part of the problem is the skill set there. And so you have to keep in consideration why that is. And so maybe that's absolutely appropriate for most systems because the systems that did well had highly skilled medics, like in the Seattle system or Houston system, where they had kind of a small, or Milwaukee, where they had a small cadre of medics doing the ALS calls, et cetera. So just wanted to tell you a little bit about what that's about, and
Okay, but
maybe,
so I'll bring you back to 2025 now.
yeah.
If you're a medical director, or if you're guiding a new medical director going out to an agency like that, and based on this guideline, what do you recommend that new medical director to do? Do you say, you know
Well,
what?
you already know that because when Paul Banerjee came to me, he talked about what to do. You know what I told him, right? I would use an advanced airway, but make sure you do some specialized skill training and make sure they're good at it. And if not, get an SGA in. That kind of control the airway, etc. It's the issue is that it's harmful when you don't do proper, breathing. That's all.
Okay, so do you think there's any medical legal risk here then? I'll throw that at you now.
Uh,
So you're an agency who uses an SGA. The kid dies, right? Because
mhm.
90% of them will, by the way.
Yeah, yeah, yeah.
And now someone comes and says, you're using an SGA, Mr. EMS, and therefore you are going against what and trust me, they will bring experts, quote
Sure.
unquote, experts against you to say that, oh, absolutely, I would never use an SGA in a kid. So
So
how does that impact the rest of us now?
So I would do what I've always done, which is I'll go and testify in those things when that's come up and not lose. Because the background, first of all, our background and understanding why that study was done and understanding all the details I just told you can do it. Yes, they can do that, but it's probably not going to happen. So I think that especially if we have a team of people like we have now that are responsible for taking care of people, and in large numbers of people, I think regardless of the hardest issue. Now, having said that, there are some places that have to use this. I have to grant you, I've only worked in delegated practice states, and that's where, but I don't do things independently. I make sure I'm talking to other people and our groups, and everybody kind of agrees. There's a consensus amongst people I respect.
Yeah. Okay. All right. Fair enough. Tanner,
And
let
then
me
let me
go.
know later if you want me to come down and talk about the other thing, but let's go to somebody
Yeah.
else. Okay.
Yeah. So Tanner, after hearing what I said there regarding the 20 to 30 breaths per minute, I would love to hear your take on this guideline change and ILCOR sticking with what they're sticking with a little caveat. What are your thoughts on this imbalance again between two pretty large organizations?
Yeah, so my seeing this, my first thought is, right, we don't really have any good evidence to suggest that either of the ventilatory rates are what is optimal for pediatric patients, right? We don't know what volumes to use. We don't know what rates, right? We don't have good answers to a lot of these questions, right? So as it is apparent, these different guideline organizations are just throwing stuff at the wall, and they're like, yeah, this seems reasonable based on physiologic rationale, et cetera, et cetera. However, we should have better answers to some of these questions soon, right? So I think Josh put in the chat the PD part trial is currently enrolling patients, right, which is going to compare a strategy of bag valve mask only versus supraglottic airway, and then it's going to compare the winning strategy to endotracheal intubation. Um, and I'm sure as a subgroup analysis, a sub study of that trial, we will be able to look at what ventilation rates are associated with optimal outcomes following pediatric cardiac arrest and ventilation in the pre-hospital setting.
You're assuming that they're actually looking at CPR metrics in those
So,
studies,
so
and they're not.
I would assume, and I would have to go and look at the study protocol. But almost all of these trials that are being done nowadays in the pre-hospital setting, at least some of the sites they have the cardiac monitor files available from which we would be able to pull CPR quality metrics. We would be able to pull from like the end tidal CO2 waveform, the impedance waveform, all of these things to do a well done observational study of this question. Is that going to be the optimal answer to the question? No, we would have to randomize kids to different ventilation rates, right? But it's better than the 46 patient study we have now, right? And so I think the real answer here is we need to generate more evidence as a field, right? Like,
Yes, I agree with you. But so here's a question I want to ask you. Now that this thing is out in the wild, right? 20 to 30, when I go around the country, there are people who just read it blanketly and just changed it. And then many of us didn't change it. We're staying at the same thing. Paul Banerjee actually went to smaller breaths, larger volumes, same minute ventilation. And that's, Dr. Pepe can allude to that. So basically, the United States has become a petri dish for testing things on children with zero evidence. And so part of what is a little upsetting to me and frustrating to me is that if you put this out, shouldn't you have come back on the backside of it? And maybe there's a study that I don't know about that's going on. They're looking at this, but this is something that's so important. Ventilation during CPR is so important. I mean, heck, we've even gone to using a ventilator, the Hamilton T1, during CPR. But knowing the breaths, the rate, the tidal volume, etc., it's like this big black box. And here we are in 2025, and nobody really has a good answer to it. And unfortunately, this guideline, this 20 to 30, is never going to come out of the guidelines unless another study comes out, and it's a reasonable study.
Yep.
That's an EMS related study. So anybody else? I see Lou. Go ahead, Lou.
Just can you go back to the ill core statement? It's a couple of slides. The other way, I believe.
Yeah, hold on. I'm getting there. This one.
So I had to read it a few times. If you look at the caveat, a caveat on the caveat is it says for cardiac arrest that occurs with an advanced airway in place. So I read that to mean, like you admitted, PICU patient, they already have the airway in place before they arrest, not applicable to what we deal with. So just a note that I saw in there.
No, I think that I read it to say that once you place an advanced airway, supraglottic or endotracheal tube, then it's move up to these rates. I mean, I don't think they're saying, at least I don't think it's just you're in an ICU or that they arrest with an advanced airway in place. But maybe
that's how I always read it, but when I reread it, if you look at the way it literally is, and we need someone from ILCOR, it says arrest occurs with the airway in place. So I'm looking at it, the chicken came before the egg.
Interesting. Okay, I like that. All right. Well,
And the other thing, Peter, this is not in context. It has nothing. It doesn't show what the tidal volume should be. It getting blood flow across the lungs and oxygenating all lung zones. It has nothing to do.
Yep.
It does not talk about how to deliver the breath and how to release it quickly. All the various techniques. I could go on and on
Correct.
about this. It's all wrong. Okay.
It is. All right. It is. I agreed. Marv.
Yeah, just real quickly, we looked at SGA issue. All our BLS providers place SGAs, including PEDS. We go down to, I don't know what, a half, incredibly low size. And we're now getting in tidal CO2 off of all of them. The problem, obviously, is they can displace, and there are a lot of other issues. Medics will intubate if the specific circumstances seem appropriate. And then their video where we've recorded it, and we look at those intubations, and we look at the timestamp. Helps. I think the question here, there's two questions. One, I've been involved with the Advanced Airway Lab at NMSP for several years now. Especially physicians, and including when we're doing cadaveric specimens and looking at the lung, physicians don't know how to bag, no matter what kind of an airway. And if you disagree with me, that's okay, but you're wrong, because I watched it, and I've watched it for years. Two, an SGA is probably better if you're going to bag, at least it creates a specifically closed environment so that a third of what you squeeze doesn't go out the sides of the mask because it takes a minimum of two people to hold the mask on and bag. Three, we we look at our outcomes. I can't tell you that SGA meant we saved more people. I can't tell you that the SGA said that we ventilated better. I can look at the entitle and understand that a little bit. But I think we're kidding ourselves. And the AHA is also kidding themselves to think a BVM, I don't care whose hands are holding it, we've got my little teeny hands, it's even worse, is adequate to ventilate anybody, especially pediatric. As far as the rate goes, Peter, I don't know. Let's all just flip coins because the data sucks. And I agree. We've made up these numbers, pal. I agree. And we make up all these numbers, but I don't know what the right answer is.
Except that Paul Banerjee published a study in 2019 with Dr. Pepe in resuscitation showing that their neurointact survival is 23%. And if you read the 2020 guidelines, they say, yeah, we saw that study, but we weren't exactly sure what led to that outcome.
Well, the interesting,
I'm not disagreeing, by the way. I'm agreeing.
Yeah,
that
I know.
Yeah.
and interestingly enough, it went up better the next year because we got the Epi on board earlier.
Right,
too.
right. Ari, go ahead. And then I'm gonna say it.
My question is really, why are we coming up with these guidelines essentially in the blind? Why are we not basing our ventilation based on some sort of reliable feedback? We talked about end tidal CO2 as one option, but it's very deceiving. We're starting a line on these patients. Why can't we do, maybe we don't have the technology. Maybe we have to get the technology to do venous CO2. Maybe we need to start A lines on these patients and get real-time oxygenation. I mean, we're just doing this in the blind. We're throwing darts against a dartboard here, hoping we get the right ventilation rate and stuff like that. It's not based on any feedback.
I agree. Is Gordon Miller, are you here, Gordon? Talk about VCO2 with Ari.
Open up this can of worms real quick. So I will say this, that the end-tidal CO2, as far as monitoring a patient's metabolic rate, is dead to me. I use that strictly for, hey, they have an airway. I'm confirming that. I compared that a little bit to VCO2. If you think, and we've talked about this as far as, the body being an engine and end tidal and CO2 measuring that. End tidal would be a sensor in a tailpipe. VCO2 is telling me exactly how much that engine is producing over a minute. It gives me a true metabolic picture of a patient. Also, in doing CPR with a T1, I'm looking at exact mills per kilo that I'm ventilating that patient. And that's something I do when I'm increasing my pressure control on that. It gives me a very accurate reading of that. Volumetric shows that, like I said, the true metabolic production of it. I'm finding alarming discrepancies in between end-tidal CO2 and volumetric. I know what the volumetric should be, roundabouts, and I can look at that patient, know their kilo, their ideal body weight, and I can look at my end-tidal, and sometimes they're not tracking at all. If I didn't have volumetric in some of those patients, I would have probably done something that would have been very detrimental to that patient. It is definitely a new technology. It's not for the masses yet, but we're trying to understand it. And I think the more people that use it, it's going to be a great thing. The one thing also I'll say about using the T1 for a past decade in CPR and working with many different agencies, SGAs leak like mad. I do not believe in any way, and nobody's convinced me that they're providing adequate oxygenation or ventilation to these patients. I believe that a measure of PEEP is needed to maintain FRC. And I believe that there is that. We intubate patients, but I will say the number one issue that most agencies call me up when I'm helping them, their complaint is, why is this vent causing these SGAs to leak so bad? We're getting 100% leaks. This ventilator flows in the 200 liters per minute range, 240, 260, and we're getting massive leaks. We're having to upsize them and change that. So there's got to be more education in that. And I do believe there's an issue that with the mechanical CPR as well. By humans, we are kind of rhythmic. And I've more than once had to correct somebody if they were bagging, starting off with a cardiac arrest or something like that, and say, hey, you're almost mirroring what the Lucas is doing. So you're hearing that pulse of that plunger, and they're doing that same thing with the ventilations. If you go back and look at your data, you may see that and track some of that in some of your ventilations. Even ET tubes leak during mechanical CPR. So that is something we have to look at, but the leaks are real.
Yeah, well, it's funny, as Paul says, all these things are not binary, and it turns out again, it's probably not the device itself, but it could be how you're using it, right? We've seen issues with the SGA. Many of us moved away from the endotracheal tube, and now it seems like people are kind of trending back towards the endotracheal tube now that we have the ventilator. So
I
interesting.
think it's like we got a hammer and everything looks like a nail.
Yeah.
And we have to understand, there's certain circumstances. Hey, let's use let's use that tool. How do we use that? Everybody,
But if you're not doing CQI and any of this, you're
right,
blind and you don't know.
100%.
So we only have a few more minutes left, and I wanted to, there's a few other topics I wanted to hit. So Ari, thanks for that question there. But I wanted Tanner to talk about next is epinephrine. So a little prelude. I'm not going to get into this today because it's not in anyone's protocols except maybe for ours. But we've removed epinephrine from our shockable rhythm protocol. Epinephrine, there's been a lot of data, not a lot, but there's been more and more data coming through. Scott Youngquist published his data on EPI-IM. It's got a tiered system, 5 milligrams EPI-IM, and he showed a 4% absolute increase in neurointact survival. He recently published that paper. The folks out of North Carolina did a one and done epi, right? So just give epi one time. But there are people who are giving, 15 milligrams of epi. Most of us have capped our epi, especially in asystole and PEA. But Tanner, can you, in a very short amount of time, give us any information here on epinephrine and what we should be doing?
Yeah, so there were two changes to the guidelines detailing whether we should give epinephrine and how we should give it that I wanted to talk about. So one of the things that I saw a lot on social media was people were saying, oh, they're defending these big money groups. Suddenly IOs are too expensive, and so they're saying go IV first. And then other people were saying they left epi in as a strong recommendation in the guidelines, and I think they should have removed it. Doesn't the evidence say that epi hurts people in cardiac arrest, right? And so I want to talk about those two. So a lot of observational data that suggests that patients who get intraosseous drugs do worse than patients that get intravenous drugs. This has been now tested in multiple randomized controlled trials, one in Taiwan, one in the UK, one in Denmark. All of these studies essentially randomize patients to initial vascular access strategies with either an IO or an IV. All of these studies essentially said the same thing. It does not matter what your initial vascular access strategy is in terms of survival and survival with a good neurologic outcome. In one study, the Paramedic 3 trial, the largest one that was conducted in the UK, suggested that if you go for an IV first, it probably improves your probability of return to spontaneous circulation in the pre-hospital setting. It's also much less expensive, right? And so based on this high quality randomized data, the AHA has gone and said, we have a high strength of recommendation. Go IV first when you're obtaining vascular access in your cardiac arrest patients. Okay, so that's the first piece of this. So they also continued to recommend the administration of epinephrine pretty strongly. Dr. Antebi, did you want to say something?
No. Oh, sorry. No.
You're good. And so they said that it's probably reasonable to keep doing it the way that we've been doing it, 1 milligram every 3 to 5 minutes. And I saw a lot of comments saying this is doing is filling our long-term acute care facilities, allowing more wallet biopsies. This isn't helping anybody, right? And so I just wanted to quickly touch on the evidence and some of the evidence that's come out since Paramedic 2, examining what this actually does to our patients, right? We're all familiar with Paramedic 2. 8,000 patients randomized 1-to-1 to either receive 1 milligram of epinephrine every 3 to 5 minutes or a saline placebo. They found epi is great at getting ROSC. It improves survival at 30 days. but it does not seem to improve survival with a favorable neurologic outcome in a statistically significant manner, right? One thing that I think is really important to understand about Paramedic 2, when you do a clinical trial, before you start, you have to do something called a power analysis, which determines how many patients you have to enroll in a trial in order to have a reasonable chance of determining whether a treatment works or not, right? Paramedic 2 was powered for survival at 30 days. It was not powered to detect whether there's a difference in good neurologic outcomes following epinephrine administration, simply because survival with a good neurologic outcome is slightly rarer than survival at 30 days, right? And so this was a positive trial, right? They set out to prove that epinephrine improves survival at 30 days, and they found that. Epinephrine improves your odds of survival to 30 days by about 50%, right? Subsequent to that, they published long-term outcomes, right? And so they looked at outcomes at 3 months, 6 months, and up to a year following out of hospital cardiac arrest. And essentially what they found in this investigation overall, just to summarize it for you, is epinephrine seems to have a durable influence on survival, right? Survival, alive and out of the hospital. And there's also a strong trend toward improved neurologic outcomes in the group of patients who got epinephrine, right? Epinephrine is not poisoning people's brains, right? It gets us more people back. It gets sicker people back. And so a higher proportion of survivors have neurologic disability, right? But overall, if you just look epi, no epi, more patients in the epi group had a good neurologic outcome, right? And this was essentially sustained at 3 and 6 months following this trial, right? They did what's called a Bayesian analysis. And so they said there's about a 90% probability that epinephrine improves neurologic outcome from cardiac arrest. However, it probably improves survival by less than 1%, right? This is not a very effective medication for resuscitating cardiac arrest patients, but it is not poison. And the evidence suggests it does improve survival following cardiac arrest, and it may improve survival with a good neurologic outcome. In fact, there's a significant probability that it does, right? And so I think some of the rhetoric has got out of control online about epinephrine, maybe even from me, right? That I've said some nasty things about epinephrine before. Again, it's not very effective, but it's not necessarily poison, right? And I think the AHA has a good leg to stand on. They have randomized data that suggests it improves survival and maybe improves good neurologic outcomes. So I wanted to say that. Now we've also talked, and I know Dr. Antevi has talked about this before. There's plenty of places that are not using it in shockable rhythms anymore, right? Paramedic 2 did not show that this improves outcomes for patients with a shockable rhythm, right? And further, on top of that, the American Heart Association, their algorithms do acknowledge that there may be harm of epinephrine, especially when administered early for patients with shockable rhythms. I think one thing that often gets overlooked in ACLS trainings and trainings that the AHA puts on is that they say that you need to try defibrillation a couple times before giving epinephrine, right? There's a number of observational studies in the hospital that show that you have worse outcomes if you get epinephrine within 2 minutes of the first shock, right? Worse survival, worse ROSC, worse functional outcome. Similarly, if you get epinephrine before defibrillation, which happens about 20% of the time in the hospital, that also decreases defibrillation success, survival, et cetera, right? And so I wanted to give AHA props there. There may be harm in shockable arrest, and they do sort of acknowledge that in their algorithms. So that's my piece on epinephrine. Happy to discuss that.
So, and listen, that was very fair. Do you think then that we're going to get to the point where we're actually looking at shockable versus non-shockable? Because I think that's where it's at, right? We didn't discuss here today as far as, amio and lido in the shockable rhythms. Should they go IV versus IO? But again, that seems to be, no benefit there as far as, I actually changed my protocol to, no epi and then give amio IV preferably, and make sure you're giving it within the first 8 minutes. And the question is, how are we going to answer these questions is my question for you, where people are looking at us saying, you removed epi? Yeah, we removed it like a long time ago from shockable rhythms. When is that, or how is that question going to be answered? People want to know.
Yeah, so I think that there are certainly additional studies, randomized studies that need to be done, kind of teasing out what is the right dose, what is the right timing interval, and does this vary by rhythm? I think those are all very important questions. I believe the Epidose trial, which is another Canadian trial, which is currently enrolling, looks at, and I think it's only among shockable rhythms, capping the dose at 3 milligrams of epinephrine and looking at whether that influences outcomes following cardiac arrest. So maybe that trial will provide some additional evidence and maybe some subgroup analyses within that trial more so. again, right, the one milligram every 3 to 5 minutes is kind of something we made up, right?
Oh yeah, it was
So
that 1968. It was a study of dogs. They had all those. They had 7 groups of 15 dogs each, and these are 10-kilo dogs. These are like basically like a 1-year-old, and that's how they brought this information in. So let's go to Dr. Ingram, and then anybody else wants to make a comment before we
Couple comments. The that sounds about the same level of evidence as sea collars, but that's another discussion. We'll come back to that. I think, and I wish the real smart guys were still on. I know they had to hop off early, the real scientists outside of Tanner. I think the real question here for does epi belong in a VF arrest algorithm is what happens after VF, right? That's what I want to know. I want to know what happens, like what are we going to? Are we shocking people out and their blood pressure is 160, or are we shocking people out and they're in PEA because they're really in a pseudo PEA and they're too hypotensive? Like they need the epi support at that point, right? Do they need it in a 1 milligram bolus? Probably not, but they need epi support. And so we say, I don't know. I think the next step is you need a good, at least observational trial to start us in the direction of what happens to the shockable arrest after VF, right? We can talk about getting them out of VF, but what happens after that? And why do they rearrest, right? If they
Well,
into VF, is
you're
it
right.
because of
Okay,
the epi or is it because of the lack of epi? We don't know.
okay. So hold on a second. Let's bring in Adam again from Lethbridge because I think he has some answers to that question. Adam, are you still there?
I am. Yep. Go ahead.
Yeah. Go ahead and talk to us about what you have found post ROSC with the amount of patients who you saw who were not getting pressors to maintain their BP, who were rearresting, and then what you did to fix that.
Well, so yeah, when we first started our cardiac survivability program here in Lethbridge, we were getting roughly 60% or sorry, about 50% of our people were getting patients back that were hypotensive. 60% of those patients were rearresting. And so what we were finding was that they definitely needed some sort of vasal support post ROSC. What we've now looked at is that we set our benchmark at 90 systolic for our blood pressures, and we've now realized that that's still not quite enough. And so we've actually had to bump up our push dose epi and our vaso and our norepi dosing. So if you are between 90 and 120 systolic, you're getting 20 milligrams or 20 micrograms Q1 to 2 minutes PRN until you can get over to your norepi. And then if you are less than 90 systolic, what used to be the EMS gold standard, we used to think 90 systolic, everybody above that was good and that was okay. And we're finding that that's not the case anymore. And so we're copying what the CANROC or the California Resuscitation Outcomes Consortium did, and we're looking at sub 90. We're looking at 50 mics, push dose Q1 to 2 minutes PRN, and then we're going 0.5 to 1 mic per kilo per minute in norepi. And so we have had, I think we've had 3 successful arrival to hospital with a pulse since we've implemented that policy, and I believe one of those 3 is a neurologically intact survivor. And so we're starting to get some good numbers now. I will admit we are a small service in terms of 100,000 people, very similar to what Dr. Antragi's services. And so our numbers are quite small in terms of a sample size. We based our data that copied California's group off of 85 patients. But it almost matches almost exactly in terms of rearrest outcomes as well as survival to hospital outcomes.
Excellent. And you guys are doing great work. Tanner, with a number needed to treat of 112, how many patients would you need in a trial to look at? For example, there are people out there who are starting epi drips, intra-arrest epi drips, right? Here in Broward County, 2 milligrams of epi in 100 bag. It gets run in so that the first milligram goes over 8 minutes, the second milligram goes over 8 minutes. And instead of it being this big bolus, and then when you have ROS, you could just tweak, you could just kind of turn down that drip so that you're actually maintaining the correct blood pressure, which is not 90, I agree. And there's data to support that it's not 90. So Tanner, what do you think as far as when is the bolus dose epi gonna leave the scene, and how do we get to that point when the NNT is so large?
Yeah. So that the thing is, right, if epi versus no epi, the number needed to treat is 112, continuous versus bolus, the NNT is likely a lot larger, right?
That's
So
right.
this would require like a national resuscitation outcomes consortium like group in order to facilitate something like that. And I'd say before we spend $100 million to do that, we'd also probably want some laboratory studies to show that from a physiologic level, does this actually do anything to our perfusion and doesn't improve in animal models, you know? I love, see, I was actually just talking about this. I do think we need a trial of we hang, so we have a double blind RCT, we have a bag of epi and we have a bag of saline, and we hook it up to people while they're still in cardiac arrest. And at the time of ROSC, someone says, yeah, I feel a pulse. You turn it up to some drip rate, whether that's 6 mics a minute, whatever we pick, right?
Mhm.
Until we get blood pressures.
Mm-hmm.
I think a big problem is, right? And so a little bit of data here, right? My mentor, David Salcido, in his PhD, whenever he studied rearrest, he showed that like 75+% of rearrests are happening within 7-8 minutes of ROSC, right? What you have is people who they're hypotensive. You say, yeah, I feel a pulse. So he says, oh, I can't hear a blood pressure. Oh, the cuff spits out question marks. So we'll cycle it again and they're dead, right?
That's right.
Those are the people that we can save, right?
That's
If
right.
you just started an epi drip, if like you said, if you just down titrate or you start an epi drip immediately upon getting a pulse, I think if we did a trial there, it would be hard to power for mortality because patients who are hypotensive post-ROSC have very, very high mortality. But if we looked at an outcome like rearrest, we would maybe a couple hundred patients and we could do it, right? Because we know meta-analyses have shown 30% plus of patients rearrest that have return to spontaneous circulation, and they'll rearrest in the pre-hospital setting. So I'd love to see that trial. I'd love to do it. I'll be writing for funding. If somebody else doesn't do it, I'll be writing for funding to do it.
There we go. There we go. You heard it here first. Adam, go ahead.
Yeah, I was just going to add in as well that the interesting thing about looking at that data and looking at the stuff that we've had is that even when you get somebody back who is normotensive, so that greater than 120, for us in our look, when we're looking between 120 and 130 systolic, we're still getting 54% of those patients are dropping to below 90, regardless of treatment, right? And so our treatment is just not aggressive enough. And so by the time we recognize that we're starting to go hypotensive, we've already missed the boat. We have to get on these things a lot faster, a lot sooner, and a lot more aggressive in order to have these positive patient outcomes.
Excellent. The great point. This is the devil's in the details. But before we end, I wanted to end on something with epinephrine for pediatrics. So ILCOR, turns out, de-emphasizes the use of epinephrine for symptomatic bradycardia. Hey, amazing. Whereas the American Heart Association keeps it in. So there's the Holmberg study in 2019 showing that, and that was about 6,000 patients, showing that epinephrine in children who have a pulse is harmful. There was another 2023 study that showed no benefit. So here we are now again, 2025, and the American Heart Association is leaving in cardiac arrest epi for people who are not in cardiac arrest. Yes, they may be getting CPR, fine, I'm okay with that. But Tanner, really quickly, from the physiology perspective, how does it make sense to be giving epinephrine to somebody with a pulse? Because if I gave epinephrine to any of you all here on the call, if I give you a milligram of epi, you would all end up with ischemia. You would all end up in the cath lab. So any thoughts on that? Oh, you're muted.
This is another recommendation based on very weak evidence. And it is certainly something like, again, there's rationale for harm here, right? If we want to answer these questions, I'm going to sound like a broken record. And for the next 50 years that I'm going to be doing EMS, or I plan to be doing EMS.
Thank God.
I'm going to continue saying this, right? If we want answers to these questions, we have to randomize people. If we want answers to these questions and we don't want to be inadvertently hurting people with these recommendations we're just making up, we have to study this in a formalized way, right? And again, like okay, and there's an observational study out there that says that people get harmed by epinephrine if they have a pulse or not. There's also like huge confounding by indication there, right? Like people who get epi are sicker, in terms of even the observational data that we're doing needs to be better, right?
But
I don't know, yeah.
Tanner, listen, I know that sounds like a good plan. However, if these are not done and we keep having some junk science, like you're seeing, there are some junk science that sneaks into the guidelines, right? We've talked about it today. You know, how do we get on the right page? And so I guess I'll end with this question. So if there are a group of EMS physicians who say, you know what, we don't believe any of these things, and we're going to rewrite the guidelines to reflect what we want to do in EMS, right? Then it just becomes, I'm doing this and you're doing that, and Charlie's doing this and Paul's doing that and Gordon's doing that. How do we develop consensus outside of the American Heart Association? That's really the main question here, who are mainly not EMS people at all, who are mainly ICU doctors. That's really the crux of the matter here. If you look at the DSED debacle that they screwed up on, and you look at some of these other scientific items that they put in here with zero, with zero reason to put it in there. I guess I'll finish off with this last question. We'll open it up as people are leaving here. How do we move on without the randomized trial, but to manage an EMS system in a way that you can feel like you're covered medical legally, that you're being supported, and that some random EMS physician, which happened to me, comes up against you in court, spouting out things that are completely untrue?
Yeah. So, and again, I don't really have a good answer for a lot of this, right? Well, one thing I will say is, NEMSP, the position statements that are put forth by NEMSP may be one mechanism by which we can do this. Like within our own organization, we can say that as a body of EMS physicians and medical directors, this is what we feel is right. Again, even within those, I mean, we've seen on this webinar, because those position statements are not based on a solid foundation of science, there are disagreements even within the calls that we've had, with the authors of those, right? So that's not a perfect solution, but I think that is one to make sure that our viewpoints and our subspecialty is represented well, and maybe protects us more medical legally. I think that also, we are seeing, although it's kind of slow over time, we are seeing more NEMSP members and even paramedics and EMTs that are represented on the groups of people who are writing these guidelines. So if you're out there, right, get involved. Write to the people who are on these committees, right? Try to join them if you're offered, right? Don't just say, "Yeah, that's a big commitment. I don't want to waste my time," right? Get involved. Like your voice, and if you're someone who's passionate about these topics, you can really make a change, right? Yeah, that would be. Is there anything I missed there that I didn't respond to?
No. I was just trying to give people the large RCTs are all the way over here, probably not really reachable for a lot of these items that we're discussing.
Yep.
The guidelines are the floor all the way over here, right?
Yep.
And then the question is, where do you, meaning each and every one of you, where do you sit in here? And what will sway you towards what Marshall Frank is doing? What will sway you to what Charlie Ingram is doing? What will sway you towards Gordon Miller is doing, or Tanner Smita? Like, I get this sense from people, because I get a lot of emails, and people want me to send me their protocols and this and that and the other thing. And I just get the sense that people are out there wondering how to swim in this big pool, and do the right thing. And unfortunately, if the only thing we're doing is waiting for the tablets to come down from the mountain, from the American Heart Association, from the ICU physicians, we're not doing anyone any favor. Having conversations like these today may have swayed someone to go and think through these topics, to maybe add double sequential in tomorrow, right? I just don't think that exists just yet. At least I haven't seen it, and I would like to push everybody who's on this call to continue to say, we are EMS. We are our own independent specialty. There's a board certification. Where the hell is it? Somewhere up there, right? We're board certified in this stuff right now, right? So I would recommend that we start to slowly but surely peel away and have our own, I would like to sit and watch a webinar of a group of EMS medical director, expert scientists like yourself and others, to say, here's the data, it's EMS related, here's what we would recommend, here's why we would do it, here's why you shouldn't do it. But at the end of the day, it's coming from the EMS organization rather than the AHA organization. And Joseph Zalkin is saying nemsp.org. If you're not a member, become a member. That should be the organization, Joseph, who's doing this. So can you unmute yourself and maybe make a couple of comments on what the organization is doing nationally regarding this?
Absolutely. I know I'm among friends, most are members, but let's face it, 20 years ago, EMS didn't have a voice. EMS physicians did not have a voice. Now we're generating fellows left and right every year. I've been at this 25 years putting fellows in the street to become EMS medical directors. Our dearth of knowledge pre-hospital is growing from urban all the way down to rural communities. There are similar observations. I'm an old dog. I'm a dinosaur. The key word is change. You've got to prepare your crews for change. You have to prepare yourself for change, and you have to ask the right question. I started out with 2 amps of bicarb and an amp of epinephrine and straightforward with a defibrillator shock 2, 3. And what did we know? We knew nothing. We didn't control for airway. We didn't have any way for feedback biologically to figure out metabolically what was happening with those patients. Our toolbox continues to change. We need to be respectful of people's time on task, and we've got to give feedback. This organization is both professionals and physicians, and I agree with you, Peter. It's a large step against major institutions, but we're the ones who do resuscitation every day. Even though it's 1% of our practice, we do it well because we do see results, but we have to hone our skills.
I agree. So let me ask you this then. How about this as an idea? I'm about to put up the CARES data for this is for the United States. This is the CARES annual report. And if I go here, and you can see here that this is a 2024 overall survival rates, and each red bar is an EMS system with over 200 CARES cases in 2024. To have over 200 CARES cases in 2024, you got to be a pretty big agency, right? You're not even in Charlie and my agencies and Paul's agencies here, we're seeing 60, 80. In Palm Beach County, we see, 700, right? 800. So how could it be, Joseph Zalkin, that one EMS system is at 3 point something percent, okay, survival. And we go all the way over here, and this is almost 22%, right? Here's what I would ask for to happen. Make all these agencies transparent. Why isn't this data transparent? Why do we have to guess who these agencies are? And how in the world could you have an 8-fold difference in survival? How could you have an Utstein here of 5 point something percent and you have an Utstein here of 70%, right? Am I missing something here? Or should we then make a move to make this data transparent? And Charlie Sands on the call, he helped us with stroke. Now stroke data is transparent in this country and it's in the state, and all of a sudden the survivors is going up. So is there a way to push people towards becoming better with the basics by making the data transparent? And I'll throw this towards you, Joseph, or even Tanner, which is, why aren't we making this information where every red bar has an agency name next to it? And maybe I'm being dramatic here, but that's
I'm all for naming names. I also think they need to be classed by rural,
fine,
and suburban, right? If you're in Amish country, maybe you do have an issue with how much manpower can arrive at a scene. I don't know that. And maybe one of those groups is in the top 10. I think you need to name your top 10. I think you need to name your bottom 10. And
but remember, these are all over 200. This ain't Lancaster, PA. I'll tell you that right now.
Well, that's
right. So, but yes, I mean, I agree. We should do that. But the problem is that when you go and start to say, let's make this data transparent, everybody looks the other way and says, oh, maybe really not. Like when you look at the pediatric readiness data, we know that only 14% of hospitals are pediatric ready, but they won't tell you which ones aren't, right? Anyway, that's just a kind of a larger point of, if you want to improve the system, you actually show people who are the performers, who are the low performers, and then the low performers have no choice but to start getting better. Right now, there's zero incentive for an agency who's at 5% Utstein, 0% incentive for that person to wake up tomorrow morning and do anything better for their system. So there are other levers we can pull, which is really what I'm trying to say here. So, Tanner, take us out with some final comments. I've kept people 10 minutes over.
Yeah, so thank you all for sticking around. I will say as kind of a final word here, again, in light of the venom that I saw on social media spewed toward the AHA guidelines, some of which is deserved, as we've talked about today. But the people who write guidelines, right, at least the ones that I know, right, many of whom are friends of the show, they've been on here before, that Dr. Antevy and I both know personally. Many of these people have dedicated their lives to the science of emergency care, right? And that's why they were selected to write these guidelines. And then on top of that, they spent months and months and months thinking about what they wanted to write in these guidelines, going over the evidence in a systematic way. And so they're really not compensated for it, right? They're doing this to try to better our emergency care systems in this country and how we take care of people, right? Resuscitation science, all of the science underlying EMS and emergency medicine is very nuanced, right? These guidelines are intended to be kind of expert recommendations about the treatment of the average patient at the average EMS agency out there, right? And always remember, there's no such thing as a free lunch. So from a public health perspective, you can always think of that patient that's hypothermic and needed 4 hours of CPR who you saved with a new toy. There's a cost, right? You might have sacrificed 4 or 5 VF patients, regular average out of hospital cardiac arrest to save that one, right? So I'll leave it at that.
Tanner, I'm going to be Tanner's agent. I predict that he's going to be booked at many conferences in the future. But Tanner, thank you so much for all of your insight today. It was very nice, the fact that I felt that today was balanced, and you really brought that balance. And you are someone who is going to move our profession in the right direction. So people like me just aren't sitting here complaining all day long. So I appreciate you balancing me out. And for anybody else, if you thought this was beneficial, let us know. We're happy to continue the conversation. Taryn and I had like 5 more topics to talk about, but we're going to have to table those because we didn't get through them today. Thank you so much. We have a Friday webinar every Friday at 11 a.m. We go over really innovative topics. And then the Florida NMSP chapter is really strong. Maybe one of the largest. I'm not going to, start looking at Joseph to count how many people we each have, but we're having a very large dinner January 30th at Tampa at the NMSP conference, and you'll be getting an invite soon. So if you're a Florida member and you want to join, Tanner is our keynote speaker for that night, and we have a very large room, and we have sponsors of Zoll, Intersurgical, and Trauma Gel will be sponsoring that dinner. So with that, thank you, everybody. We will see you next time. And Tanner, thank you so much. And good to see you again.
Thank you.
All righty. Bye-bye.